Okay, I'm Barbara Lang. Many of you know me. Welcome. I am the Office Chief for Behavioral Health Licensing, and I've also been working a lot going out to some of the assisted living and skilled nursing facilities, so thanks for coming today. How many people here are in a skilled nursing facility? Show of hands. Skilled nursing, okay. Assisted living, okay. And behavioral health. Wow. Okay. Well, you guys are going to be the experts. I don't know if I'm going to teach you anything new, but I hope that at least you gain some valuable information as we move forward with the rule changes. So what I'm going to start out with first is just some basic tenets of what's happening and where we got to where we are today. So hopefully this looks familiar to you. If it doesn't, please jot down this website. This is the integrated website, and this has all the information for any trainings at the bottom of the page. It has the draft rules on there. It has Article 1, which has the definitions and how you facilitate your facility as far as policies, procedures, environmental, and what's required. So this integrated website is going to have everything current on it. Any trainings that we do, such as this one, is always live streamed and then videotaped and stationarily put on the website so that you can watch it later. So if in the event you have a colleague that wanted to be here, wasn't able to make it, they can watch the training at a later date on this website right here. Yes? Yes. Okay, so what are we going to do today? We're going to talk a little bit about integration, how we got here. We're going to talk about the timeline for how we're going to integrate it. And we're also going to discuss the differences between behavioral care and behavioral health services, or like we say in rules, behavioral health services light. So then we're going to have opportunities for questions and answers. You can ask me anything related to some of the regulations with the rules that we're working with in behavioral health or some of the other subclasses as well. And it should be about an hour roughly. Okay, so the objectives today are to understand the difference between behavioral health and behavioral care. I'm going to go through the importance of doing treatment plans and assessments and why we do those. I'm going to show what's in them for folks who are unfamiliar with treatment plans and assessments. And it's also to understand the differences in the requirements for persons that work in behavioral health services, because for some of you, that's foreign information. Okay. So why are we doing this? About a year ago, we enacted our strategic map, and that shows the winnable battles that the Department of Health Services is interested in. And one of the big focuses for us was on serious mental illness, because we know through research and evidence-based findings that persons with mental illness have a much shorter lifespan. So what we wanted to do was capture those clients and be able to meet all their needs in a holistic way, so that when they went to the clinic, they could also meet with a primary care practitioner and have that opportunity. Because as it stands right now, we really are siloed. If you're in assisted living, you can't do behavioral health, or at least the rules didn't accommodate for it. And then if you're in behavioral health, you weren't able to do that personal care and do assisted living services. And then if you're in a behavioral health clinic, you didn't have a primary care doc. And so really to address the whole needs of the person. So here's our strategic priorities. I talked about winnable battles, integrating physical and behavioral health, to really promote public safety and to strengthen the state system and maximize effectiveness. So when we say promote safety, one of the challenges that we had is in years past, the rules were really written for reimbursement purposes. So what we wanted to do was take out all those money pieces and make it about health and safety and return to regulation. And for a lot of folks, that was pretty exciting because you would be able to define your own destiny. So we're really operating now from more of a certification standpoint. You know, if JCO or CAR for certification, COA comes out, they'll say, what are your policies and procedures, and hold you to those. These rules kind of match that set a lot better, a lot more. So you're going to be defining things, and whatever you define, we're going to be holding you to it, rather than having that prescriptive nature and saying you have to do A, B, and C, and then you might not be doing it. So this gives you the opportunity to say, hey, I know this population, I know what they need, this is what they need, this is what we're doing, and then following up and doing it. Okay, so again, this is about public health and safety. And then integrating physical and behavioral health services, which is what we talked about. Now, the House bill was what allowed this to be facilitated in the first place, and it reflects that on or before July 1 of 2013, these rules go into effect. And we are going to be filing on June 28th with the Secretary of State. Those rules will go in. However, there will be a delayed implementation till October 1st. What does that mean? That means that you have an opportunity to update your policies and procedures to the new rules. It means that when a surveyor comes out, they're going to hold you to the current rule set until October 1st. So if you have to do physical changes to your facility, if you have to have staff trained in new skills and knowledge, if you need to update the different things in your manuals, you'll have an opportunity to do that. So there's going to be a lot of technical assistance, a lot of hand-holding, a lot of learning on our end and your end to really help you be successful as you proceed. Okay, so these were some of the things that really, when we looked at doing integration, we wanted to focus on. Now, one of the things is we didn't want to put an undue burden from a regulatory standpoint. I talked about really lifting the prescriptive nature of these rules and allowing you to define what it is you do and do it well. It was also designed to reduce and streamline cost. You know, you're not going to have a series of surveyors. You're going to have one surveyor, one application. So before, if you were doing both services, you'd have to fill out a medical facilities application. You'd have to fill out a behavioral health application. Now you're going to have one application. So it's going to save time as well. Okay, so when you license a facility, you still have to act within your scope. You can only practice at the highest level for which you're licensed for. So for example, if you're an assisted living facility, you can do personal care, but you can't do an outpatient surgery. If you're a residential facility, you'll be able to provide personal care, but you won't be able to provide secure care or inpatient care. So you'll only be able to provide the level at which you're licensed to provide. If you're performing nursing services, that needs to happen by a nurse. If you're performing behavioral health services, that needs to happen by a behavioral health professional. People need to perform within their scope. And hopefully that's been happening now. We want to make sure that people have the skills and knowledge to meet the specific needs of the clients without going outside of their scope and standard of practice. Okay, so the timeline. Like I said, there is a delayed implementation of October 1st, and the department's going to be doing a lot of specific trainings. So we have more trainings that are coming up that will be drilled down for your specific subclass. So we're going to have some assisted living training, some skilled nursing, some behavioral health for residential, outpatient, primary care. So we are going to be holding things, and all those will be posted on that website on the link that I gave you in the beginning, and it'll come back at the end as well. So I think we're pretty clear. Starting October 1st, follow the rules. Starting October 1st, follow the rules so you know what's coming. Update your policies and procedures and your staffing and your training accordingly. And then what is integrated healthcare to begin with? I think most folks are pretty familiar with it, but if you're not, it really is the marriage between physical health and behavioral health. Detection, treatment, and follow-up. We're all doing the same thing, and that's addressing the issues that the client has. I mean, the exciting part is that we know there's no health without mental health. And a lot of times when people go see their primary care doc for, let's say, hypertension, they may not realize that some of the things behind it are anxiety-driven. So this gives people the opportunity to do that warm handoff and have a professional intervene that has the specific skills to do so, which is very exciting. It also reduces the stigma for people who struggle with mental illness. They get to stay in their clinics, they get to be familiar with the staff, they feel safe there. Because we know a lot of times we lose clients when we refer out and they have to go somewhere else. So staying within the context of a provider they feel safe and comfortable with really is a win-win. I thought this cartoon kind of expressed it all as far as integration. Are you depressed because you have diabetes, or is diabetes causing your depression? Yes. Okay. So what is behavioral health services? Now I'm going to talk about behavioral care, but this is behavioral health services, and to perform behavioral health services, this needs to be added to your license. This is a specialized service or carve-out. So behavioral health service is any medical service, nursing service, health-related service, or ancillary service provided to an individual to address specifically the individual's behavioral health issue or condition, a mental disorder, personality disorder, substance abuse, or psychological or behavioral response. Kind of a long definition. So that means addressing someone's behavioral health issues specifically through counseling or other means. We do have ancillary services going on right now in a lot of our facilities. We've seen a lot of acupuncture coming about. We've seen chiropractic as an ancillary service. We've seen energy work, massage. We've seen spiritual healers getting involved, a lot more holistic approach. If you do add an ancillary service such as that, you want to make sure if that service requires a license, that person be licensed to perform that service. So if you're allowing for chiropractic, that person be a chiropractor and be able to show the certification and licensure required to do that. Medical services are defined in statute as our nursing and health-related service, and those services define a healthcare institution. If you're performing any of those services, that's what justifies being licensed, and that's what our department has oversight on. So we talked about ancillary services. Why do an assessment? An assessment really is the first step to determining what a client needs are. Assessments are extremely important, and that's why a lot of times surveyors will say, you didn't update your assessment. I have to cite that. That's why, because if the assessment isn't updated, then the treatment plan's not going to be very good. A treatment plan really is only as good as the assessment that you provide. Now, all of the things in this assessment are currently in the rules now, which can be found on our licensing website or the Secretary of State's website under the rules. So these are all things you don't have to worry about jotting them down quickly. They're going to be up on the web, and they're also currently in the rule set. But these are things like what's going on, the presenting issue. Is it depression? Is it anxiety? What's happening that has brought that person in here? And then we're talking about a history. We're talking about a health history, might be a criminogenic background. We're looking at that. Has this person ever been arrested? Has this person ever been hospitalized? What's the family history? These are all things to help you determine how to best meet the client's needs and develop that treatment plan. It's continued on. Now, sometimes your facility is unable to meet the needs of the particular person that's there, and you might have to do a referral. So it's important, if that's needed, that you document that in the resident's record, and you put the referral source and the condition with which you are referring them for. And that's fairly common. You might have a client whose significant issue is behavioral health, but they have an eating disorder, and you don't have anyone in your facility that specializes in that, and you may need to refer them out to address that specific issue. You want to make sure you document that and make sure the person you're referring them to has the skills and knowledge in which to meet that condition. Now, the treatment plan comes after the assessment, and that is really the action steps that you're taking with the client in order to address whatever issues you've identified. It's very important that if you say something is going to happen in the treatment plan, that it happens. So if you put in the treatment plan that you're going to address a specific issue by doing individual therapy one time a week, what the surveyor is going to do is they're going to look at the treatment plan, and they're going to make sure if you say I'm doing counseling one time a week, that those progress notes are in sync and you're doing counseling one time a week. We hold you accountable to what you say you're going to do, and that is the big theme in this rule set. If you say you're doing it, you need to do it. So don't put something down that isn't attainable or that you don't have staff to follow through on. So the treatment plan needs to be completed by a behavioral health professional or a behavioral health technician under clinical oversight. And I'm going to talk about the differences between clinical oversight and direct supervision and some of the people involved that work in a behavioral health facility. It's also important that the treatment plan happen before any physical or behavioral health services are had, or, not and, or within a 48-hour time period. Okay, this is the treatment plan continued. Now, a treatment plan is considered the medical record, so it's important that it be filed. Any physical or behavioral health services provided, it's got to be signed. If a client refuses to sign it, that's okay, but you need to document that on the treatment plan, because a lot of times when we receive complaints, we make sure that the client was invited to cooperate and participate in the process, and if they chose not to, you have to make sure that you document that accordingly. Okay, so who are the people? These are folks that you traditionally see in behavioral health, and like every field, we love our acronyms. That's why I spelled them out, because when you start talking BHTs, BHPs, and all those things, people get pretty confused and say, what the heck does that mean? So these are what they stand for. A BHP is a behavioral health professional. That could be a psychologist, it could be a psychiatrist, it could be a counselor, a social worker, a licensed substance abuse counselor, a baccalaureate level social worker, marriage and family. There's lots of different persons who are licensed to perform behavioral health service, but these are your licensed people. One of the things that people ask me on a regular basis is, does that count as an associate level person? So an associate level counselor or an associate level substance abuse counselor. Yes, it does. Because in behavioral health rules, it says a licensed person, and those persons at the associate level are licensed. So they do qualify as behavioral health professionals, so they can do that supervision with BHTs. However, they have to be receiving supervision themselves. Everybody get that? Okay, and I can always go backwards. A behavioral health technician or a BHT. There's a big change in this rule set from the last rule set. Previously, behavioral health technicians were able to do clinical supervision with BHPPs. A BHPP is more of a novice behavioral health professional. It's just kind of breaking in the field and gaining the skills and knowledge and experience to get promoted to a BHT. Now, in the new rules, a behavioral health professional is the one that has to do that direct supervision. So BHTs cannot do that any longer. However, a BHT or behavioral health technician can supervise lower level employees on non-licensable activities, case management, psychoeducational groups, living skills groups, things that wouldn't require a license such as counseling. So you can utilize them to balance out the time that your behavioral health professional needs to do their paperwork and do their oversight. And then lastly, in that category is the behavioral health paraprofessional. That's more of your novice employee, someone that's gaining the skills and knowledge. A lot of times they're new to the field. Previously, in the other rule set, we were very prescriptive. We talked about the level of education they had to have, the years of experience they had to have, and one of the things that we got was a lot of feedback. People would say, you know, I have this person who has years and years of experience, and they just don't have the schooling, and I completely think they're qualified to work with this population, but maybe they don't have any college. We heard you loud and clear. So what we did is we changed it, and we're allowing you all now as providers to determine what level of education and experience someone needs to have to operate as a BHT and a BHPP. And I've heard some pretty neat creative ideas from different people. I would really suggest folks network. I've heard a lot of providers saying we're going to get together and develop some standards in our field. If you specialize in a particular area like children with conduct issues and so on. Also, the Human Service Council, I've heard, is working on getting some uniform definitions for these particular fields of practice. So it's good to talk amongst yourselves, network, and it's always helpful to get other people's opinions. I've also heard some people are developing a BHT1, a BHT2, and then a BHPP, so people can work up as a progression towards promotion to a behavioral health technician. But you determine that, you decide, and we hold you to that, because when we come in, we're going to look at the job description. We're going to look what you say they have to have, and what do you think we're going to do? We're going to look in the personnel record, and if you say they have to have a minimum of a GED, we're going to make sure they have a GED, because you're setting that standard, so you have to follow your own standard. And then we have peer recovery support specialists, also known oftentimes as just peers or support specialists. They are an exceeding important role in our system, and we're seeing a nice increase in the peers that work in different facilities. I've seen them working in medical offices, behavioral health offices, residential settings. These are folks who they themselves or family members have been involved in the system and utilize that experience to empathize, connect, and assist others. So this is just by definition what a behavioral health professional is according to statute. And these are people obviously that are oftentimes licensed in a variety of ways. They could be licensed under the medical board, psychological association. They could be licensed with the board of behavioral health examiners. Oftentimes people have different certifications or specializations under their role. But these are your licensed folks. And like I said, it's under the associate level as well. Again, behavioral health technician. Somebody who can perform a service that would otherwise require a license, specifically counseling, but is under the supervision of a behavioral health professional. Now, we didn't use the word supervision in the rules because it has another meaning. We use clinical oversight, and I'll talk about that and explain what that means in just a minute. Then you have your behavioral health paraprofessional. Like I said, this is your employees just breaking into the system oftentimes, kind of at a novice level. And they have direct supervision, which is different from clinical oversight. And then your peer support specialists. And I really like this definition. An individual who is a BHT or a BHPP who's progressed in their own recovery from alcohol or drug abuse or a behavioral health disorder and is willing to self-identify as a peer and work to assist other individuals with chemical dependency or behavioral health disorder. And it's because of that experience they can lead such a good connection. And peers are, I just think, very important to the system and the whole idea of recovery in general. Okay, so clinical oversight. Clinical oversight is specific to behavioral health technicians. And we used to call it supervision, but it encompasses more than just supervision, because when I think of supervision, I don't necessarily think of it in this significant of a manner. So these are the pieces in red that are the most important when you're looking at clinical oversight. Monitoring the behavioral health service, making sure that the person is qualified and that they follow the policies and procedures as laid out by the facility. And we're going to make sure that your behavioral health technicians were oriented those policies and procedures. One of the things that's very disappointing to me when I go to survey a facility is when I talk to the employees and they say, gosh, I know what I'm supposed to do, but I was never told how to do it. So if you're going to put something in action, make sure you orient your employees so they know what the expectations are and how to get there. That's a very important piece. Then you have to provide ongoing review. You don't want to tell them once. We want refresher trainings, right? Because a lot of times over time people forget things, and sometimes we get folks with specific needs that change, and so you want to make sure they're staying abreast of best practices and evidence-based. Also provide guidance. You're the one with the experience. It's very important that you utilize those experiences to help teach, mentor, and coach them as to what needs to transpire to really benefit the client and work with them fully. And then recommend training. If you think there's something specific they can benefit in, like motivational interviewing or trauma-informed care is a big one today, have them take it. There's lots of free trainings that the Department of Behavioral Health Services offers, that our REBAs offer, Magellan, Simpatico, CPSA, that people can go to free of charge to stay abreast of what's the latest. Now, direct supervision. This is for your lower level paraprofessional employees, folks who don't have the level of experience but want to get it. How do they get it? They get it by someone doing direct supervision. Now, that someone has to be a behavioral health professional, licensed person. So I took this directly from the Board of Behavioral Health Examiners website. It has to be a licensed person that provides that direct supervision. So this person has the immediate responsibility. That means if they're doing assessments and treatment plans, you got to be sitting there with them. Now, before, a behavioral health technician could do that, but now it can only be a behavioral health professional. And the reason we did that was, sadly, we had quite a few bad outcomes that resulted as people going way outside of their scope of care, and they didn't have the qualifications to be able to navigate situations to provide other people with the knowledge base that they needed. So that was a decision that we ran by the stakeholders, that we talked to a lot of clients and providers about, and that was why we made that significant change. Yes, of course.
Looking for behavioral health examiners, at least as for me as a psychologist,
Mm-hmm.
because I can serve as a supervisor to a associate counselor.
Yes.
But because of my scope of practice, I can't serve as a supervisor to a marriage and family therapist,
Mm-hmm.
social worker,
Mm-hmm.
or substance abuse counselor.
Now that would be someone getting their licensure.
An associate.
Right. But you could do clinical supervision if it wasn't towards licensure. Yeah. Okay. Does everybody understand what he asked? He was saying that it would be outside of his scope as a psychologist to perform clinical supervision for someone whose specialization differed from his. So if you're someone who's working towards licensure to be individually licensed, to be an independent person, you have to match that scope. So you could do supervision for the purposes of satisfying compliance within the rules, but that doesn't satisfy hours for someone through the Board of Behavioral Health Examiners to be independently licensed. I know it's kind of confusing, but I can certainly go back and talk about that later in the questions section if anybody needs a little more clarification on that. Yes? Sure.
So, BHTs are clinical oversight?
Yes.
Or are they also direct supervision?
No, only behavioral health professionals are direct supervision. Yeah, your novice employees. Behavioral health technicians can act on their own. They can do assessments, they can do treatment plans, but they have to have that sign off by the behavioral health professional, and they have to be receiving that clinical oversight, which is supervision.
The direct supervision is the paraprofessional?
You got it.
Okay.
You got it. So what's behavioral care? Behavioral care is something a little bit new to behavioral health folks, and this was addressed as a way of the department meeting the needs of things that were already going on. I don't think we were under any illusion that assisted living and many skilled nursing facilities weren't getting referred behavioral health folks from the healthcare plans. So we wanted to figure out a way to make sure those standards were in place for health and safety so folks in assisted living and skilled nursing could work with behavioral health clients, but that there were parameters surrounding it and that the persons that were doing that work were qualified to do so and the environments were safe. So we came up with a definition for behavioral care. We worked very hard on it. It was written and rewritten many, many times, and I think we've nailed it. And this is kind of a behavioral health services light, what have you. So if you're doing this behavioral care, you would not have to have anything added to your license. This would just be a parameter with which you have to follow. So behavioral care is assistance with a resident's psychosocial interactions to manage the resident's behavior. It can be performed by an individual without necessary license skills, or a caregiver, may include direction provided by a behavioral health professional and medication ordered by a behavioral health professional, or or a medical practitioner. What does that mean? Because that's kind of wordy. That means that if you're doing behavioral modification, strategies and techniques to deal with behavior in assisted living or skilled nursing, that's not going to require a special license for behavioral health services. And I'll give you an example. If you have somebody with advanced dementia who's really struggling with symptoms, and every time staff walk by, they spit, that would be an aversive behavior, right? We want to address that. We want to stop the spitting. So perhaps there's a behavioral modification technique that you talk with the staff about to reduce spitting. That would be put in a behavioral care plan, an addendum to the service plan that would allow you to address that conduct issue. So it really is behavioral modification. It's not continuous behavioral health service. It's addressing those aversive behaviors that are often found in dementia, Alzheimer's, or your more medical issues. Could be a behavioral health person whose primary issue is more medical in nature. So this allows assisted living and skilled nursing to do behavioral care and do it with some standards. So in those facilities, what we are asking, and they're going to be in the new rules, is you'll have your service plan, and then aside from your service plan, you're going to have a behavioral care plan. And that's going to be described in that plan, and it'll assist the administrator to understand what things are required to meet those conduct issues.
Excuse me, I have a question.
Uh-huh.
Regarding the medical practitioner, which, you know, it's the same scenario, demented resident.
Mm-hmm.
So the physician, obviously, or nurse practitioner or sort of behavior modification thing. I get that. Who would be able to be the behavioral health professional that actually assess the patient? Could it be the wellness nurse? Could it be the registered nurse on the campus? Could it be the assisted living manager?
Okay.
Or does it need to be a behavioral health
Okay.
professional?
So what she asked is when you have a person who's exhibiting behavioral issues and you want to do a behavior modification plan using techniques and strategies, who is allowed to assess the client to make that determination? Many facilities have social workers and counselors. Certainly they would be appropriate, or the medical practitioner. If it's a psych nurse, but it has to be someone that's available to have that auspice to make that determination. So these are the things that for behavioral care must transpire. These are the criteria. Evaluate the resident before you accept them into your facility. You want to make sure that you're able to accommodate them. For some assisted living facilities, they may not be able to do so if they feel that person's behaviors are beyond their scope, or it would compromise that client's safety to be in a home that wasn't secure or had certain environmental factors in place. Review what services your facility offers. Agree that this is an appropriate placement by having a signature by the BHP or the medical prac, and then provide a summary of the behavioral care that the resident requires and reassess that every 6 months as appropriate.
Now, can a nurse do this, the evaluation, the assessment?
It has to be a behavioral health professional or a medical practitioner. So it could be a nurse prac, qualifies as a medical practitioner. So a behavioral care facility must summarize the resident's mental and emotional conditions or impairments, making sure that they follow the medication that's ordered, they identify those goals, and they must be reviewed by the BHP or medical prac and update the service plan when there is a significant change. And that would be updating the behavioral care plan as well, because if there's a change in the service plan, there's going to be a change in the behavioral care plan.
Yeah, the care plans can still be done by the nurse, right?
Yes, correct. So what kind of skills and knowledge do people have? One of the big changes, as I said, was we were very prescriptive in defining the roles of what persons did, how much education they had to have, how much experience they had. So when we talk about skills and knowledge, these are the changes in rules that allow you to define who's qualified to do what. The type of behavioral health services or behavioral care expected, you establish a job description for them. So if you think that 3 years of experience working with a specific population is enough, then that's what you do. But you also have to consider the acuity. If you have someone who's very high acuity, has high propensity for acting out, you may not want to put them with someone very young and unseasoned who doesn't have experience. So you really want to make sure that you have the appropriate person with the client. You want to think about that very long and hard, because we're going to hold you to that standard. So it's really important that when you sit down with your team to make decisions surrounding that you identify things that are workable in nature and meet the needs of the clients. Goes on that these are things that you want to consider: the duration and type of education. It might be college, it might be GED, it might be high school diploma or some type of equivalent. It might be special certifications if you're working with a population that's specialized. And it would also be how much experience do you think they need to have? 6 months, 6 years, 1 year, and define that in the job description. But you're making that determination. I thought this was a pretty neat visual that really, for me, encompasses integration or collaborative care. It says the behavioral health system is the head, the physical health system is the body, and then we're combining them by including the neck. So I thought that was a nice visual. Okay, so questions. Anybody have any thoughts or concerns or wondering? Yeah.
I'm curious. Okay, so my background is assisted living. So
Okay.
Basically, all the other stuff doesn't apply to me other than the behavioral care, right?
Well, she's a background in assisted living. Is it only the behavioral care that applies? It is behavioral care that applies. However, you can provide behavioral health if you would like to do that. You can add that to your license. There are some folks through the healthcare plan that have people coming in and doing counseling or contract with a psychiatrist, a psychologist, or counselors, and they want to add behavioral health services to their license. You certainly could do that. You could do it later on, or you don't have to do any of these things. If you want to be specifically a medical provider, an assisted living provider, a skilled nursing provider, or behavioral health provider, you can do that in isolation. I think the thing to think about, though, is that a lot of folks will be providing these integrated services, and so that may make some determinations as far as referrals and where folks go.
But if you're providing behavioral care, you don't need that license, right?
Correct. If you're providing behavioral care, you do not need to add behavioral health services to your license. Now, it's not a special license. You'd still be licensed as assisted living. You would just have a menu of services underneath it. Yeah.
So do associate level BHPs need to be supervised?
Do associate level BHPs need to be supervised? They have to have that clinical oversight if they're getting their license.
No, I mean, if it's already a BHP, I mean, it's already a BHP on the associate level, not a BHT.
Right.
An LAC or.
Right.
So they still need.
They have to have supervision. Yes, they can't operate independently. They can do supervision for BHTs, but they still have to have that supervision.
Okay, so a BHP on the independent level has to supervise them within the agency?
Correct.
Okay. Under the clinical oversight?
Yes.
rules? Okay.
Correct.
Not the direct supervision?
Right. You got it.
Okay.
Perfect. Anything else? Boy, you were an easy group.
One more.
Sure.
So the BHPs that are licensed independently, they don't need to be supervised?
Right. The BHPs that are licensed independently do not need clinical oversight. They're acting on their own accord under the auspice of their license. Correct. Yes.
Under assisted living policies and procedures, do you recommend having how can I say this or ask this, having a separate policies and procedures for dementia care?
So she was asking me, do I recommend a separate policy and procedure for dementia care? I don't think you need a separate policy and procedure for dementia care. If you felt there was something specialized that you wanted to do to highlight or a significant amount of training specifically for that population, you could certainly do that, but it's not required. Anything else? Yeah. Oh, no problem.
So the supervision is there, I know at the last meeting we were talking about how often that needs to happen. Is there, we come up with a time frame?
Yes. So she asked how often does that supervision have to happen, and we actually looked that up yesterday in regard to the rules. You just have to document every 2 weeks, but it's up to you whether you want to do it weekly or monthly.
Say it again?
You have to document every 2 weeks that you've reviewed, but it's up to you whether you want to offer it weekly or monthly. Some people like doing it weekly, or you can document monthly.
But how often do we need to provide it? Is my question.
You make that determination.
Oh, okay. So
Yeah.
we just
Uh-huh.
decide
Yeah.
It has to be documented every 2 weeks,
Yes.
even if you meet with them monthly?
Yes.
So what would you document in 2 weeks if you meet with them monthly?
Well, you would have to touch base and document that you've reviewed and that you're going to be meeting with them the following month.
Okay, like when we review
Yes.
assessments and
You got it.
Okay. And is that going to be in the rules?
Yes.
Okay.
I'm kind of confused a little
Okay.
bit because you're saying that it would be a good idea to get the integrated license, I guess, right? The behavioral health licensing? Right?
Well, it would open up opportunities for you to work with all clients. So it's really up to you if that's something you want to do. You would still be licensed as assisted living. You would just have on your license behavioral health service. So you'd have to have the capacity to provide it. So let's say Mercy Care, Bridgeway, or one of the healthcare plans had a client that would benefit from counseling, your facility would be able to accommodate them. Otherwise, if you didn't have it, there could be a referral to another provider that did have that
Because
service.
it seems like we mainly deal with people who have dementia or
Mhm.
Alzheimer's. We don't really get into.
Yeah, if you don't have clients that can benefit from that need, it probably wouldn't make sense for you. There are some clients who are in advanced dementia that can still benefit from that, but certainly based on the continuum you're working with, that would be something you'd want to talk to your team about. Yeah. Yes.
The
So the National Council of Behavioral Health recently started working on the mental health first aid.
Uh-huh.
Is the Department of Licensing going to be participating in it or attending?
You know, that's really interesting. He talked about the department participating in the mental health first aid. All of my staff were required to attend and did. I know a lot of the staff at the Department of Behavioral Health Services did. Certainly that's something I can talk about, but most of us have been trained. We've already participated in it. Yeah, we thought that was really important. And we mentioned it in our newsletter, too.
Will that be, when you have licensing, CPR and first aid are requirements?
Yes.
Will the mental health first aid be coming to that?
You know, we didn't include that as a requirement. We can certainly provide providers with that information. One of the things that is difficult in rule is to name specific programs because rules are often in effect, as many of y'all know, for 10 or more years. So when I name something specific like mental health first aid, if they ever change the name of it or it morphed into something else, it's captured in that way and then the rules won't be updated. So you hold people to that standard. So we can certainly bring it up in our provider education trainings that this is available. If you want to give me a schedule, we can even pass things out and put it on our website. But it isn't something that would be captured in rule. Yes?
I just want to clarify, I had heard something just as early as at the end of last week, that the legislation had extended till next year, April. And I heard that from a reputable source in terms of, and so, but I've heard both from both programs, quality management program as well as this program, that it is October 1st. So I just want to clarify that.
Yes and yes. It is October 1st. However, with skilled nursing and assisted living, it has been opened up until April to allow for some fine tuning because this is a process in which we're going to see what works and what doesn't work. All of the other subclasses will be completed during that July time, and we are filing in June. But assisted living and nursing homes are going to be looked at up until April, yes.
Wow.
They
You wanna-
will all be filed June 28th, yeah, with an effective date of October 1st.
Effective date October 1st.
Yes, everything.
So will they, I hate to be repetitive. but
No, that's okay.
So October 1st,
Mhm.
if a surveyor walks into an assisted living, will they be surveying under the new rules?
Yes.
Even though it's skilled and AL has been extended?
Yes.
Can you let me what, I don't understand that. What does that mean?
There's been two so-called extensions, I guess. There's one in the budget bill and one that was done in a Senate bill. They both essentially extend our time for exempt rulemaking up until April 30th of next year. Because of how far we've gotten, we would like to file all the rules on June 28th with an effective date October 1st. And if there's some issues that come from those new rules being implemented between October 1st and April 30th, we can fine tune, like Barb said, or tweak the rules accordingly to have them just better off for the public.
I see. That makes sense.
So it's our own quality improvement. It's kind of seeing what works, what doesn't work, and working out the ticks. You got it. Yes?
So for behavioral health facilities, the main change is that we will now define what constitutes a BHPP and a BHT.
Yes. He asked for behavioral health facilities. Will you now define a BHT and a BHPP? Yes, you will, and we'll hold you to that definition. The other big change for behavioral health services is behavioral health facilities will be able to provide personal care. Now, in the past, that wasn't allowed. So persons who needed to be transferred to a restroom, lifted with a gait belt, have assistance showering, washing, dressing, bathing. That was not allowed in the new rules. It will be allowed. You can add personal care services to your license, which will be very nice because people can age in place. Because traditionally, we were pulling people out and putting them in assisted living, so that'll be a balance for our clients. However, if you add personal care services to your behavioral health license, you have to have that training. It is a caregiver training, and our assisted living folks can tell you it's pretty extensive. It's quite a few hours hours, and then you have to pass a test. And that information is available on the website. So it is an extensive process. It's not something that is quickly done. And it covers a wide scope of areas, from medication to behavioral health to, safely transferring people. So it's pretty extensive. Integration goes both ways. Absolutely. Yes?
Do these rules run all the way through from anywhere your DSPs to P&Os?
We do not have jurisdiction over the regional behavioral health authorities. Those are driven by the Department of Behavioral Health Services downstairs. Those are contract driven. And a new contract was awarded to Mercy Care and Maricopa Integrated Health. There is a stay right now by Magellan that they're working through. But they will have their own contractual requirements to follow through the Department of Behavioral Health Service. So these rules govern healthcare institutions, the facilities that perform health-related service, medical service, and nursing service. Anything else? Yes?
Just had a question about the fine-tuning period.
Sure.
Does this apply to skilled nursing, assisted living, or is it all?
The budget bill, I believe, allows it for everything.
Anything else? Okay, well, thank you. Oh, one more?
The clinical supervision piece again.
Yes.
Documentation.
Clinical oversight or direct supervision?
Direct supervision.
Okay. Direct supervision is for BHPPs.
Mm-hmm.
Has to be done by BHP.
Right.
Yep.
How their frequency.
Well, it's defined either weekly or monthly. You define that.
So what did you mean by documented every 2 weeks?
You have to document that you've reviewed every 2 weeks.
Reviewed.
What it is that they're doing that you define they can do. Because you're defining that now. You may not everybody, if they're doing assessments and treatment plans, it's just a check-in that you've checked in with them and that you're going to be seeing them either monthly or weekly. So you're aware of what's going on. Do you have the language?
No, actually,
Yeah.
Documented it right then. So I don't understand.
Well, it's for people that wait monthly, really. I mean, if you're doing it on a weekly basis, it's a little bit different. It's to make sure people just don't wait till the end of the month and have no contact at all.
Oh, I see.
Yeah, so it's a check-in to make sure you understand what it is they're doing, but maybe not a full-blown supervisory.
Okay.
Yeah.
All right. I think, okay.
we're still developing the language.
Yeah, the language is still being wordsmithed, so I apologize for the confusion. Anything else? Yeah.
So the other change in that is it's not just BHTs, it's also BHPs that are not licensed independently.
That's always been that way.
Okay.
Yeah.
That's what it means. The time frame is the same.
Yes,
Okay.
correct. Yes, ma'am.
Under Article 114, it does say that clinical oversight has to occur at least once a week.
Yeah, that's been changed. The drafts that are posted now, there have been quite a few changes since they've been posted. So she was referring to what the verbiage is clearly right now on the drafts. That has changed. So it's been modified.
What has it been modified to?
Well, we haven't got the language down all the way yet, but you're going to be making the decision as to weekly or monthly, and then if it's monthly, you're going to be needing to document every 2 weeks that you've checked in, you're aware of what's transpiring.
And that is for clinical oversight as well as direct supervision?
That is for clinical oversight and direct supervision. Yeah. Yes?
So shall we expect more drafts to come under skilled, AL, and behavioral?
No.
So the drafts that are up currently are the final?
No.
No, we are filing, probably close to 800 pages by next Friday.
Oh, okay.
And then that'll be essentially the rules you follow.
So it'll be posted, all the rules when they're finalized will be posted on the licensing services website for ADHS as well as the Secretary of State website. They can be found there. But don't worry, we're going to be working with folks over the course of time up until October. We're going to be doing a lot of technical assistance, a lot of hand-holding, making sure we're not seeing and citing it. So it's going to be a learning process. The staff are going to have to acclimate to the new rules just like you are. So if you have questions or concerns, reach out to the people that are within the division. We all are going to be in it together, and we want to make sure that your facilities are successful. And then for the skilled nursing and assisted living, we want to know what works. We want to know where the speed bumps are so that we can address it accordingly and get a rule set that works for everybody. Yes?
So will the final rules be posted July 1st for us to look at?
We can post what we file, but keep in mind the Secretary of State may tweak what we submit,
Okay.
and then they'll have a published thing probably about a month later,
Okay.
which will be a little bit more official.
So we'll look at like August, maybe?
You'll have what we filed close to the 28th. I mean, it's gonna be hard to upload 800 pages if we file at 5 o'clock on Friday, so it may be a couple of days.
Yes, ma'am.
That was your warning, Gannon.
The information covered here, when can you review that?
That will be on the integrated website that I showed in the first slide.
Get that. Okay.
Let me get that up for you.
It should be posted shortly too.
It's right there, that www.azdhs.gov with the /ALS/integrated/. Yes, ma'am.
The technical assistance that you keep referring to,
Yeah.
is that through the surveyor of the day, or is that different?
The technical assistance can be through the surveyor of the day or it can be your directed surveyors. We're going to be doing a lot of cross training to make sure all the surveyors understand what the expectations are for behavioral care, behavioral health, and that they are open to talking with folks about what the changes are and how your facility can address those changes.
We'll also be doing technical assistance by watching this website, and you begin to look at the different categories. You may find that there's going to be assisted living rules, at a location on this particular date. So that's why this website is it's the first go-to website almost every day for us, because it's constantly moving, and it'll provide some of that technical assistance on what are the rules, what are we going to be looking for, as well as the surveyors in the field.
Anything else? Okay. Yes. Sorry.
One more time.
Sure.
The intake provide personal care services.
That personal care services class is listed on the website. It's identified in statute. It's through the Nursing Care Association. I can email it to you. Yeah, no problem.
About the caregivers?
Yes. If anybody needs to contact me after or has any questions, I'll leave my cards up here. Feel free to take one, or if there's something you don't want to say in front of the group, I'll be here for a few minutes if you want to talk. Thanks so much. Appreciate it.